Thanks so much, everybody, for showing up today. I have a 7-year-old who knows the work that I do, and he asked the question, Dad, where are you going? I said, I'm going to Atlanta to talk about BPD. He says, they have BPD in Atlanta? So I think it's so wonderful to see the NEABPD here. I mean, they've just done an absolutely wonderful job, and such wonderful friends with Jim and Perry and Trish and the Halls. And I really encourage people to join the NEABPD. I'm sorry, I'm doing a plug there, Perry. But I think, it's a 7-year-old asked that question, and I think it's true. I mean, the public acknowledgement of this condition just isn't there. And so tremendous credit to NEABPD. Okay, 3 East. So there I was at McLean in 2000, seeing a lot of what I thought were borderline patients, and said, I think that we need to do a dedicated treatment unit because the kids that were coming in who I thought had BPD were coming in on polypharmacy. So here you had these lovely young people, now overweight and with acne, talk about self-esteem problems, trying to deal with emotion regulation, and a lot of these medications weren't helping. And I thought, we have dedicated eating disorders units, dedicated psychotic disorders units, etc. We need to have dedicated adolescent BPD units. So I proposed this for about 7 years to the administration. And there were jokes like, what do you get when you put 2 borderlines on a single unit? Those sorts of things. That it was going to be chaos, that security would have to move into our building, that people would be tearing each other apart. So they said, all right, you can have a unit. We expect an average daily census of 2 for the first year and see how that goes. This is our 4th year. We've just opened up our 26th bed. And I think that they're going to get filled up pretty quickly. We've also got a partial program that has 12 beds dedicated to the treatment of adolescent BPD. We've had more than 400 patients come through our units, and that's just the residential unit. Okay. So to me, the idea that we had to wait until 18 to make the diagnosis made very little sense to me at many levels. And John Gunderson, in private conversations, has admitted to me that he and people who developed the idea of BPD with him are really to blame for this misconception. And whenever I spoke to adult patients with borderline personality disorder, they recognized that their symptoms started in adolescence and maybe even earlier than that. So what did we have to do? Wait until they turned 18? So, you've been diagnosed with bipolar disorder and major depression, ADHD, and you get a phone call from your psychiatrist, happy birthday, you're 18 now, let me tell you you're borderline. And then when you speak to clinicians in the community and they talk about people who present with symptoms of BPD and trying to come up with something, they say, well, it's borderline personality disorder. No, we can't do that. Makes no sense. Anybody who's got more than one child knows that personality evolves in childhood. I mean, you get, kids and they're very, very different. It almost doesn't matter how you raise them. They've got their own little personalities and they continue to evolve. And our personalities continue to evolve. They get a little bit more fixed the older we get, but nevertheless. And then the other thing was that the DSM was very comfortable diagnosing other psychiatric conditions in early childhood and adolescence, so why not personality disorders? Okay, now, interestingly, John Gunderson actually referred me an 11-year-old, and I was very happy that he'd done it at many levels. First of all, that he was recognizing, to start to pay attention much earlier on. So this is a young woman whose father has a diagnosed major mood disorder, and mother is emotionally reactive, although I don't know meets criteria for BPD. And the parents fight a lot. And so what this girl has discovered is that when they fight, she cannot stand it. And what she's discovered is that if she takes her skin and twists it, and what she calls a monkey pinch, never heard that term before, but anyway, a monkey pinch, that it helps her to regulate her mood, and it helps her to stop or distract from what's going on in the household. So this is really interesting stuff. Already this child, 11 years old, has discovered a way of regulating herself that involves this monkey pinching. Well, you can see where this is going to go. Okay, well, maybe the monkey pinching doesn't help so much, and are there other ways to self-injure that are going to help her? Now, I would not make the diagnosis of borderline personality disorder in this 11-year-old girl, but what we're seeing is early indicators of something, of patterns of behavior that if they continue, will go on to become something much more problematic. And this is just an amalgam of many of the young women that we treat on our unit. So this is not a specific case, but I've just taken pieces from various histories. So 17-year-old Maria, multiple hospitalizations. Many of the kids who come to our unit have had multiple hospitalizations. Generally depression, suicidal ideation, self-injury. Often these really bright girls. And I hate getting into conversations with them because they'll outthink me and out. So I said, no, we've got to stick with the emotion regulation stuff. Let's leave Descartes out of this, you know. But it can be quite captivating. Oh my God, this is really interesting, you know. So, but they're often quite bright, but yet fail out of school. She feels that she has very few friends and that others can't possibly like her. She's traded sex for drugs and alcohol on multiple occasions. Feels that sex with boys is the only way to get them to like her. And some to many of the relationships have been abusive. She feels she deserves it. She's a bad person and she deserves to be treated badly. She acknowledges that drugs, alcohol, sex, and self-injury help to regulate how she feels in the moment. She cannot stand being in herself a lot of the time. There's a lot of self-loathing. She feels intense shame and guilt about doing what she does to provide relief. So she does these things to provide relief, a lot of sex, self-injury, and drugs. But then in moments of clarity, sort of feels very ashamed that she's done these things, feels more of these emotions, and then goes back and does what she knows best. She's remarkably attuned to nonverbal communication, and so she's able to read, those faces, the angry face that Brian had shown us, and just very exactly. I kind of saw it as angry too, a little bit. Makes you think. But they're very attuned. But the problem isn't the attunement. So often it's there. It's then the attribution. It's, okay, you're angry, and you're angry because. Or even that you're angry when you're not. So it's all right. Now, historically, clinicians saw BPD as an extreme form of adolescence. And somebody asked me once, what's the difference between adolescence and BPD? I don't know. No. But there's, okay, so I imagined identical twin children who are doing exactly the same things, and one is BPD and one isn't. So how can you tell the difference? So they're both having lots of sex, they're both having, using drugs, they're both driving fast. What's the difference? And to me, the key difference is the function of the behavior. So, typical adolescent goes and says, I'm going to try out some weed and do a line of coke and drive a car fast. But you know what? Life is going okay. But for the borderline adolescent, often those behaviors are done to regulate how they're feeling in the moment. So, they can also do typical adolescent things. But for them, often, the function of the behavior is to regulate how they feel in the moment. John Gunderson talked about this yesterday. Actually, I was in Grand Rounds, and they said that the transaction between a child and a parent actually goes both ways. So one of the things that happens is, yes, you can have parenting where you're yelling at your kid and all of that sort of thing, but that a child who is irritable and who is angry and who's just whining and crying all the time is going to elicit reactions in parents, so that there's a transactional piece to this. It's about 50-50. What do they say? Insanity is inherited. You get it from your kids. But that there's this transactional piece, that a child that is difficult to placate is just going to elicit bad parenting, in quotation marks, in you. Ineffective parenting at times. So historically, adolescents were seen as promiscuous and manipulative. Now, I'm going to make a provocative statement. I don't allow the word manipulation on our unit. Now, this is very antithetical to the thinking of many, many people who work with borderline patients, because they are quintessentially seen as manipulative. But I want you to start thinking about what the word manipulative means. If I do the same thing over and over again, I get the same result, I'm going to continue to do those things. It's just learned, classically learned behavior. So if I go to mom and say, Mom, can I have $10? No. Dad, can I have $10? Yes. Oh, she just manipulated you. She got $10 out of you. Well, I'm going to continue doing that if that's the way that it goes. Now, so what happens is that often behavior's just repeated and learned. It's throughout nature. That is not to say that manipulation doesn't occur. But the effect of feeling manipulated doesn't mean that the intention is to manipulate. I could be saying something to you, and you could all say, well, we're feeling manipulated by what you're saying. I say, well, okay, that's the feeling that you have. My intention may be to manipulate. So there's the intention to manipulate, the effect of feeling manipulated, the effect of not feeling manipulated, and the effect of not intending to manipulate. But often we throw out this word that is exactly what the intention was to manipulate. So I want you to just rethink the idea of manipulation. And the other thing is this, and Marcia Linehan has talked about it. If they're so good at manipulation, then why do they end up in hospital all the time? Why do they end up in treatment all the time? Not very good. If they are manipulators, they're terrible manipulators. Historically, BPD was a condition that clinicians refused to treat, and we get referrals from clinicians who say, well, why are you referring the patient's suicidal? So, well, I don't treat suicide, which is really sad to hear in mental health, when it's one of the most tragic outcomes of many psychiatric conditions. So a lot of people not interested that much in BPD per se, at least in the clinical aspects of BPD, have done research on this in any case. And what they do is they do questionnaires and community samples. And so what we find is somewhere between 1% to 3% of community-dwelling teenagers have BPD. And on inpatient units, it rises up to about 50% of adolescents and 42% in young adults. So now, and we saw earlier data on 20%. So it's a big number of inpatients that have comorbid BPD. And it has implications for our mental health care dollars, given how much is there. So if you're only treating the mood disorder but leaving out the BPD, and you get a lot of recidivism, a lot of people coming back in, we're missing something really important. Now, I'm going to just talk about the criteria as we see it in adolescents. Now you need 5 out of 9 criteria according to the current DSM, and Ken will talk about the DSM-5 and stuff like that, but up until 2013, you still need 5 out of 9 criteria. All right, so frantic efforts to avoid real or imagined abandonment. So what we see on our unit is that people who come in often after a breakup with a friend, a breakup with a roommate, a fight with a parent, somewhere where they feel that they're going to be left, abandoned. There's a profound sense that that person won't come back. So what happens is, in some of these cases, this is where it can feel manipulative. So what happens is, I'm afraid that you're going to leave. I'm feeling really suicidal, and I'm going to make a suicide attempt, or I make a suicide attempt. I'm in the emergency room. I can't believe you were going to leave me. The person on the other end feels terrible. Oh my God, I didn't know that you felt so bad, and then gets reconnected with the person. And so what happens is that the person with BPD under that circumstance learns that, oh, if I express suicidality, then I get a certain response. Again, learned behavior, just classically learned behavior. And so the problem is that the well-intentioned caregiving of that sort of thing can actually increase suicidality. And we have protocols on our unit where if one of our patients gets hospitalized on the residential unit, we tell the parents they cannot visit their kid in hospital. Now, you've got to be kidding me. I've been visiting my kid in hospital 100 times. Well, how's that working for you? You know. So the point is that hospital isn't a place where people are going to come and visit you, and that we actually start to reinforce behavior that we want. And once we do that, it happens once or twice, they don't get hospitalized again from our unit. Unstable relationships, so it's characterized by over-idealization and devaluation, so that there's this idea that, you know, at 1 minute you're the best parent in the world, the most wonderful human being that ever existed. Just give it 10 minutes. And it's often a reflection of all or nothing black and white thinking. There's this idea in BPD of this idea of granularity, so that for many people who don't have BPD is that they can begin to see the granularity, the detail, the finer detail of, think of a painting, you know, that you see all the subtle shades. That for BPD, it's very black and white, switches very rapidly. On hospital units, hospital staff divided into good staff and bad staff. It's great when you're on the good side. Switches. Oh, now I see what happens. And often on units where this isn't paid attention to, this idea of splitting, and again, that's another word that we don't use on our unit. We don't talk about splitting. And you know, so you're on the good and you're on the bad. Well, now I'm in the bad, and I know what you mean, and all this sort of stuff. And you can get so much more infighting. In the meantime, the patient's suffering in the background. And that these designations are often mood dependent. So if I'm feeling good, then you're a good person, and if I'm feeling bad, that you're not so good. This unstable sense of self. Now, the problem with adolescence is that adolescence is an unstable sense of self. You know, you're trying to define who you are. So if you start thinking about needing to meet 5 out of 9 criteria, using the unstable sense of self criterion in adolescence is a very difficult thing. So now you're down to 8 criteria. Now you have to meet 5 out of 8 criteria. Because adolescence is a time of changing ideas, of changing your gender identity, changing your sexuality, changing how you see the world, your values and your morals, and all of these sorts of things. So it's a time of fluidity. But what they describe more than anything else is this sort of sense of porousness. It's a sense of very rapidly taking on the identity of other people, other people's emotions, very rapidly belonging to whatever the culture is. Much more so than other kids, you know, that they seem to switch groups from one to another. Parents will say, you know, I don't know, God, she was goth last week and this week she's wearing pom-poms. I mean, you know, I don't know, something like this. And they recognize that other people have a better sense, but they're still trying to struggle with it. But again, it's not a criteria that's very easy to define in adolescence. Dangerous impulsivity. Now the DSM criteria talks about driving fast, sex, drugs, and all of that stuff. But when you're talking about 12, 13, 14-year-old adolescents, they don't have access to cars. They don't have access to, you know, if they're doing drugs, it's not hardcore, it's some weed here and there. Not many of them are necessarily sexually active, although we definitely see a lot of sexual activity even in the younger ones. So the dangerous impulsivity, if you're just saying, okay, well, no, it doesn't drive fast, you know, again, you can lose that criterion. But you see impulsivity in other areas. You know, they run away from home, or they, you know, they will spend money that they don't have, and stuff like that. And we also see, in terms of dangerous impulsivity, that we've had a whole spate of adolescents who've come in who are, you know, hooking up with much older people. Recurrent suicidal behavior. This is, now, I have to just say something. I'm talking about obviously the unit that I work on is people who've made lots and lots of suicide attempts. So this is not true of a broad group of patients with borderline personality disorder, but nevertheless, almost everybody who comes on our unit self-injures, mostly through cutting, but we see punching, breaking of bones, and more lately we're seeing this phenomenon of what we call insertion. So what happens is that they make these small little cuts in the skin and then put foreign objects under the skin and then self-suture them up. So it leaves this sort of festering wound. It's very, very difficult to treat once they start doing these sorts of things. But it's a very specific form of self-injury. Most of the people have made suicide attempts, and often by overdoses. But we've had people who shot themselves, people who've made hanging attempts, jumping in front of cars, driving cars into poles. And again, that these behaviors can be reinforced by the loving attention of, my God, my poor child, I'm so sorry, I didn't realize that you were suffering. And that by, not to say that we don't care, but it's that can be reinforcing. Okay, so the affective instability, so sort of a hallmark is that they feel things quicker than others and with apparently less provocation. They feel things more intensely, and there's longer to get to baseline. Now, I tend to think of myself as someone like this to a certain extent, so that I tend to feel things pretty deeply. I consider myself quite sensitive and feel things more intensely. The capacity that I have is to regulate that. Now, if we can start moving away from constructs that call these behaviors manipulative and intentional, and believe it as a skills deficit rather than a choice, then we can start talking about something that I've been thinking about, more of habilitation rather than rehabilitation. So the idea in rehabilitation is that you have a skill, you lose it, you break a leg, and then you rehabilitate so you learn how to walk again or whatever it is. But habilitation is an ability that you don't have that then you acquire. So if you don't have the ability to regulate, learning that is going to be critical. So that's the difference between those of us, and many of us who are in the mental health community are often quite sensitive and have the ability to a greater or lesser extent to regulate. All right, chronic feelings of emptiness. In adolescence, this can be expressed as boredom. It's often temporarily relieved with a lot of these risky behaviors, and I hope Ken gets a chance to talk about some of the findings in research that talk about the opiate system in the brain. But it seems like self-injury and drug use and everything can trigger just feelings of well-being. And so some people think that the opiate system's involved with that. Often it's expressed as loneliness. And for people who want to be so incredibly connected to others, to feel lonely is absolutely intolerable. And I can imagine how desperate that must be, just to want to be connected and not being able to. Okay. Now another criterion is anger, and they say, so that regulation of anger is difficult for people with BPD, and I think that that's true. But I think it's true of all their emotional states. So that if you're going strictly by the criteria, you say, well, does the person ever get angry? And say, well, no, not really. But they experience intense sadness, experience intense shame, intense guilt, and other emotions. So I just think that when we're looking at the criteria, we should look at any intense emotion, not just, yes, controlling anger is a difficult problem, and it's difficult for parents, it's difficult for clinicians, but it's difficulty regulating any of these emotions. Paranoia and dissociation. So we often find comorbidity with post-traumatic stress disorder, and I think that as we start to look at the DSM-5, people are talking about this idea of complex post-traumatic stress disorder looking very, very similar to what BPD looks like today. But what's interesting, and Mary Zanarini is now my embedded researcher. She's hovers around our unit because we have so many BPD patients, and it's very interesting to see how they evolve. It turns out that only about a third of them, using really broad criteria for trauma, meet criteria, have been abused. So a third. The 2/3 haven't, and that the majority of them come from absolutely well-meaning, well-intentioned, loving, compassionate families. Often there's a tremendous misattunement, a mismatch, and kind of an emotional mismatch that happens with their kids, in ways that kids don't feel understood and ways that parents don't feel understood. And when you get that on a repeated, an ongoing basis, that you can see the evolution of BPD, which is more the DBT-Linehan theory. However, once they've been traumatized, added to BPD, it becomes really, really difficult to treat. Because often what you can do is you can reduce the self-injury and suicide attempts, but what happens is that the PTSD symptoms are not treated. And now, in traditional DBT, you had to wait for a very long period of time before you started treating trauma. We're working with new models where trauma is dealt with as soon as 8 weeks after at the end of the target symptoms, after people have stopped cutting and stuff like that. Because often working with traumatic memories can reactivate a lot of BPD symptoms. And so it's something that we're looking at, and we're developing protocols for that right now. Okay, now these are just other things that we see on our unit. So these are not in the DSM, but I see it clinically a lot. So often they talk about tremendous self-loathing, feeling evil, feeling contaminated, feeling that being in a relationship with other people will make them toxic. And often, I had this one young woman who said, that she was in a group with somebody and that one of the group members' children had died, and it was absolutely certain that it was because of her. And she didn't want to be in therapy with me because she thought that bad things would befall my life. And if anything bad happened, but she could never, always seen through that lens of that negativity, because if good things happen in my life, well, that would be discounted. This profound sense of hopelessness and self-hatred, and like what Ken was talking about, that it's not depression, but we don't have good words for this. So we call it depression, and then people are treated with antidepressants, often many of which don't work. Again, the school performance. This idea of also connecting emotionally rather than anatomically or physically. So what happens is that often the connections, especially romantic and sexual connections, are with people they feel connected to. It's got nothing to do with gender. And so even though they will often identify as heterosexual, parents will often come in and say, well, I don't care if they're gay or homosexual. It often doesn't have to do with sexuality per se. And many of these kids will be in relationships with various genders, but it's got less to do with the gender specificity rather than the way that they feel connected to emotionally. This complaint of being universally misunderstood. I think that one of the things that happens on our unit is the reason we haven't had security move in and all of that is that when you're in an environment where other people understand how it is that you're feeling, you're connected with other young people who have similar problems, that you feel more understood and you feel that there can be more hope. Again, this attunement to nonverbal communication and very susceptible to others' emotions. Okay, so what's the difficulty? Well, the difficulty in getting treatment is that even though we often begin to see symptoms early on, we miss an opportunity to treat. So here's this 11-year-old who's twisting her skin, but she doesn't meet criteria for any psychiatric diagnosis, so we're not going to treat her. We'll wait until things get worse. The problem is that, on the other hand, if I'm treating her, well, what am I treating her for? Well, I'm treating her for twisting her skin. That's what I'm treating her for. Well, no, you have to have a criterion, otherwise we can't bill for, we can't submit for insurance purposes. So what do I say? Do I say she's depressed? Well, then why aren't you treating her with an antidepressant? Do I say she's personality disordered? Well, I don't think she's personality disordered. So what do you call this? And so, we don't want to jump on personality disorders, because if I'm doing it with 11-year-olds, what about 8-year-olds? What about Ken's person who was in the womb there? How far back do we go? treating, people aren't signing up for this because treating adolescents with borderline personality disorder, it's like that one, not me. I'm not touching this case. You know, it's somebody else. Somebody else do it, because I'm not ready to deal with all the stuff that goes on. The messages at 2 o'clock in the morning on your cell phone that said, you know what, you didn't answer your phone, I'm done. The leaving the session and just being totally devalued as they walk out. Looking like they're doing so well and then the next day falling apart. You feeling as a clinician, this is where ego comes in, that you personally have failed. It's ego, you know. It's me. I'm such a good therapist. See how well they're doing? Well, now I'm a terrible therapist. See how you can't show me up this way. Start doing better. So anyway, okay, early intervention. Now, sadly, because 95% of the literature has been done in adults with BPD, we're only just beginning to catch up. So we're now doing the study with Mary Zanarini, and we're enrolling a lot of patients with adolescent BPD to see, is this actually BPD? I mean, can we formally make this diagnosis going forward? And I think we've enrolled 60 patients in our site. And we're going to, you know, we saw the study with 392 patients. So this will be the adolescent equivalent. But because of that, there really haven't been good studies in terms of treatment. And there's actually been only one randomized study of early treatment of BPD. And it's called cognitive analytic therapy, developed by, well, the person who did the study was a guy called Andrew Chanin in Melbourne, Australia. And they did cognitive analytic therapy, it's too complicated. I mean, I'm not going to get into the details of it. But everybody does cognitive analytic therapy who's doing cognitive analytic therapy. The other thing that maybe Brian hadn't mentioned is that with all of these treatments, everybody who's doing the treatment is doing the same thing. So that's another commonality between a lot of these treatments, is that when we're all talking the same language and have common ideas about what we're doing, we're going to get better outcomes. So everybody who's doing this treatment is doing cognitive analytic therapy. So anyway, they looked at a 24-month group where they did treatment as usual versus cognitive analytic therapy, and they found rates of improvement. You can read that. So there's all these other treatments for BPD. We happen to use dialectical behavioral therapy. There is going to be a lot of research coming out on DBT in adolescents. But the thing is, it's very difficult to randomize, because here's the thing. In order to randomize, okay, so when I was speaking to Marcia about this, I said, look, people come into our unit, and after they leave, their rates of hospitalization go down, the rates of suicide attempts go down, the rates of self-injury go down. Well, I mean, we can attribute it to our treatment, but maybe something else. The only way to do it is to truly randomize. So what would you do is you would have a wait list. You would have, okay, these people go in, and you tell somebody else, listen, I'm sorry that your kid's trying to kill himself, but can you just hang on for a bit? And it's certainly antithetical to American practice to do that. So, but what they're doing in Germany, Martin Bohas and his group, they're looking at adolescent DBT studies where they have a DBT unit, and then they get people on a wait list, and they say, look, if you participate in our study, then you can move to the front of our wait list. I don't know if that would be allowed here, but it's certainly allowed there. And so now you're going to be able to compare DBT treatments to treatment as usual, or to waiting or not getting treatments. But certainly in adults, I mean, it has a lot of compelling evidence, and anecdotally, and just the outcomes from our unit seem really good. And a lot of people move to the Boston area after they've had treatment just to continue this work. But we do need better outcome studies. For a lot of these other therapies, it's very difficult to do in adolescents. So transference-focused psychotherapy is a very psychoanalytically rich psychotherapy, and movement seems quite slow. Mentalization is something that we use on our unit. We are beginning to add that as a treatment module, but we stick with strict DBT. Medication, so about a quarter of the kids who come to our unit almost everybody comes in on polypharmacy. Kent spoke about that, and about a quarter leave on no medications and just feeling a lot better. Because I think that what happens, so kids had 12 hospitalizations. They get admitted. What happened? They were depressed. All right, here's your antidepressant. They get to the next hospitalization. What were they doing? Well, their moods are up and down, and they were yelling at me. Okay, here's your mood stabilizer. What happened? Well, they were dissociating all over the place and cutting. All right, here's your antipsychotic. They go into the next one. Oh, they were very anxious. So here's your anti-anxiety agent. So this Adamed, because you're seeing someone in a slice in time, and then, people are getting, so they come in and they're zombie. Why are you here? Oh. Can you talk? Oh. They're so shut down. And you start removing the medication, and now what happens, now you can start to see the dysregulation. Well, that I can do something about. Because now we've got, we can start applying some of the skills that we treat people who didn't have them in the first place. And there's no evidence that medication is going to add a capacity that you didn't have to start with. All right. So just to... the literature is beginning to come out on adolescent BPD, and I actually had some other slides that there's a researcher in Florida, Marina Bornolova, and I always get her name wrong. But what she has done is she had no interest in BPD, but she was doing a Minnesota twin study. There, 2,500 pairs, and she just started looking at various symptoms, and took some interest in BPD and found that in adolescents, in children, BPD symptoms appear to occur in about 3 to 4% of the population. And if you just followed these people over time, between the ages of 17 and 24, with no clinical intervention, there was a dramatic drop-off in symptoms. So, it's great to do treatment during that time, because then your patients are going to look really great. But it could be just because their brains are maturing. There's this idea that brain, it's a brain maturation problem. I see it as a neurodevelopmental disorder, not that much different in some ways than autism. So, we can talk about that if autism is hyper-focused and very unaware of others' emotions, this is almost the opposite side of the same coin. But it's a sort of a neurodevelopmental disorder that with genetics and environment all influencing each other, and adolescence thrown in. But anyway, from 17 to 24, it begins to drop off. And by the way, those of you who have adolescents, it looks like adolescence ends at 33 now. So get them out early. Think, if there's a few take-home messages, think about the way that we use our language. Oh, they're just acting out. What the heck does that mean, acting out? We say this, they're acting out. Acting out what? So try to be behaviorally descriptive. Try to understand this as a skills deficit problem rather than just misbehaving. And you can have a lot more compassion for somebody who, if somebody, doesn't have legs and they can't run, you're not going to blame them or that sort of thing. If there's a deficit, if there's a problem with that, you're going to have a lot more compassion. So if you see this as a skills deficit problem, that compassion can come from both parents and treaters. So skills deficit is this. If I didn't know how to write with a pen, we take writing for granted, but it's a skill that you develop over time. And so the idea is that, so if you didn't have it, you'd say, my God, everybody else can do it, but I can't do it. So I'd say, okay, I'm going to teach it. But I don't say, well, take out your handwriting skill and write a letter. You just, write a letter. So this idea that it just evolves over time. So your capacity, if I yell at you right now, you might then feel flustered, but then regulate and not go and smash my car window in. Well, I hope not. So now your ability, you don't think about how did I do that? You don't think about, So you've got a capacity to do that, and it's a skill, but you don't think about it as a skill. But if you didn't have that skill, then I'd have to go out there and make sure that you don't have a brick with a window, because it's just not built into you. It's not wired in. It's not something that you've learned how to do. There's a lot of theory about why that happens, which we can talk about at some point. So the skills deficit is an incapacity, something that you don't have that lots of other people have. But because the majority of us have it to some extent, you think that somebody else should have it. It's so obvious. I mean, you never think about a skill until you don't have it. If you can walk, you don't think of walking as a skill. But, break a couple legs and suddenly you're saying, all right. Rethink manipulation, again, not to say that it's not manipulative, but just take a second and be curious about the function of the behavior. Just think about it a little bit. I mean, it may be manipulative, but more often than not, it's just learned behavior. This idea of habilitation versus rehabilitation, that dedicated treatments are emerging, so that these aren't, people that we're going to lock up for the rest of our lives and never take care of. We've got to continue to develop the treatments, and then we must persist in ongoing efforts to increase public awareness. And Perry was right. I'm so busy because we were opening up our 26th bed, but she called and said, "Can you come and do this?" Yes, because it's such an important mission, a critical mission. And again, people can join the NEABPD. So that's it. Thank you very much, and I'm sure we'll take questions in a minute.